Well, thanks so much for coming in. So my name is Richard. I'm an Alzheimer's prevention neurologist, and today we're going to be trying to talk about things that you can do and that we can do together to try to reduce your risk of Alzheimer's disease. Now, just to be clear, there's no one definitive way to prevent Alzheimer's disease. I can't give you a magic pill or a magic potion or whatever. But what we're going to do today is I'm going to try to learn everything I can about you. I'm going to learn about your medical history, about your family history, about your hobbies, about your nutrition, everything. And then we're going to transition and we're going to review a variety of things about you. So we call it the ABCs of Alzheimer's prevention management. And what I mean by that, and I can show you a picture, is we get a lot of deep dive information about you. And today we've already gotten a lot of that information. The A stands for Anthropometrics. Anthropometrics is basically the body composition, percent body fat, lean mass, things like that. Then the B is going to be blood biomarkers. Blood biomarkers is basically nutrition markers, cholesterol markers, inflammation markers, and metabolic markers, as well as some genetics. And finally, C is for cognition, so cognitive function. We're going to set a baseline, see how your brain is doing in different areas, not just memory, but also higher order processing called executive function, language, processing speed, and then of course memory as well. Make sense?
Mm-hmm.
Okay. How did you hear about the clinic, or what made you decide to come in?
Well, I have I have a family history in my family with Alzheimer's. My father, my grandmother, and the other three were not blood relatives, but people that I took care of, and so I spent a lot of time educating people and about caregiving and you know writing about it, and I began to become aware that, so it starts, right, I know it starts early, 20, 30 years old. Now I'm 57, and it's like, oh, like, am I screwed, or like, is I too late, or what can I still do, or, and so hearing that there is this sort of intervention window, that got me really, excited to find out, because also, I'm postmenopausal. I feel like I forget words sometimes, and some my kids like make fun of me, like, oh, you're writing about Alzheimer's, but now you can't remember like what you came in the room for, and you just start thinking, well, wow. And so because I have this background, learning about health and we're communicating about health in other ways, like, well, why not like see where I stand and if what I can do and how to.
That's great. Yeah. It's empowering, I think. Knowledge is power. You got to grab the bull by the horn, so to speak. And once you learn that there is something that we can do, if you look at the data, 1 out of 3 cases of Alzheimer's may be preventable if that person does everything right. The other 2 out of 3 cases, well, we probably can't prevent it outright, but if we can delay it by 6 months, a year, 2 years, or 5 years, and in that time frame, that blockbuster drug comes, well then, effectively, through changes that a person made by oneself, through precision medicine, like we'll talk about today, that person's really prevented their own Alzheimer's. So that's the goal.
But what is like the windows? Like, am I at the end of the window?
Yeah.
Like, or how do you define that?
We'll talk about that.
Okay.
I'm going to do a pretty detailed history,
Okay.
and as you said, Alzheimer's starts in the brain decades before the first symptom. But what we're going to do is we're going to start by taking a pretty comprehensive history. Basically, the Alzheimer's prevention clinical history is something that most doctors haven't exactly heard about, but when you hear it, it makes a good deal of sense. And then what we're going to do is we're going to take those ABCs, the anthropometrics, the blood biomarkers and genetics, and then the C's, the cognitive function, to really be able to paint a better picture of what your risk may be.
Mm-hmm.
So it's all about risk assessment and then early intervention.
Mm-hmm.
Make sense?
Mm-hmm.
Okay. So, where were you born?
Royal Oak, Michigan.
Where did you go to high school?
Warren, Michigan, suburbs of Detroit.
Okay. Where was your class rank?
I was 18. I have a class of like 600 and something.
Great. 600 and something. So that's top 3%, give or take.
I couldn't do the math. I thought I was about 5%.
Okay. Cool. You take the SATs or ACTs?
I took the ACTs.
Okay. Do you remember what your score was?
I think I scored a 28.
Okay.
I'm pretty sure that was.
Was it stronger in writing or stronger in math? Or do you
Way
remember?
stronger in writing, way hard in math. I had a tutor to help me squeak through that.
Okay. And the reason that I ask you these very specific questions is because one of the most important modifiable risk factors of Alzheimer's disease, and I call it modifiable, but it's early life educational attainment.
So did you say you call it modifiable? Because I wondered, like, well, if it happened already, is it too late for me?
So it's one of these funny modifiable risks because you, at this age, you can't exactly change where your trajectory was, but I think for future generations, if we're talking about educating people in college or high school students about Alzheimer's, which we're just starting to do now, keep bringing the conversation earlier, it's something that staying in school may lower your Alzheimer's risk or delay the onset. So after your high school, you went to college?
Yes.
Where'd you go?
University of Iowa.
Cool. You're going to be playing in the Pinstripe Bowl at Yankee Stadium in a few weeks.
Oh,
pretty
wow.
cool. If you want to come back in late December.
Go Hawkeyes.
Yeah. And what was your major?
Double majored in journalism and American studies.
Okay. American studies. Okay. What was your GPA?
I don't know. I graduated Phi Beta Kappa, so it might have been like 3, whatever, 4. I don't know how they define them.
Okay. So around 3.5.
Oh, it's at least 3.75 or something like that.
3.75.
Yeah.
Okay, great. So, and what'd you do after that? Any other degrees?
No.
No. Okay. So the reason why I ask you these questions is to trying to figure out what your academic trajectory is. Okay. Now, believe it or not, academic trajectory may actually predict what your genetics are. So you've heard of the Apoe4 gene, right? Apoe4 increases risk of Alzheimer's a little bit. Well, what we see very commonly in a practice like this is if someone starts off in high school doing really, really well and then they maintain that trajectory, they're probably not Apoe4 positive, which is a little interesting. Because if you have the Apoe4 gene, babies that are born with the Apoe4 gene, believe it or not, have smaller brains. Okay? Alzheimer's disease is a whole life course disease, and a lot of people don't realize this, but genetics actually start in the womb, right? So I haven't looked at your genetics yet, but your academic trajectory and cognitive attainment is very strong. It will decrease your risk of Alzheimer's by a little bit, and also it probably predicts that you don't have the Apoe4 gene. Now, I may be wrong. We'll take a look at that in a little bit. Okay. But I'm going to put myself on the spot in this one. Okay. So we talked about education. Let's talk about some other things. Diet. Tell me about your nutrition patterns.
What do you want to know about them?
What do you eat?
I think I eat pretty well because I live in California. It's hard not to. I could tell you like a typical day. I eat almost the same things. For like breakfast, I'm either having oatmeal with berries and
what kind of oatmeal?
Steel cut
Great.
kind of oatmeal.
Great.
And I usually make it with like 2% milk and water, and have.
Is that grass-fed milk or regular?
Yes.
Great.
Yes.
Great. You're getting all the check
that's my
marks.
California thing. That's been so it's easier to get.
Grass-fed milk is higher in omega-3s, and steel-cut oats are higher in the slowest digestion and higher in fiber, so they're less insulin spiking. So, great.
So some days I'll have granola. I make my own granola, and I'll have that instead with the berries and like Greek yogurt, also organic, grass-fed, Strauss Creamery. And then I will have like a salad with like tuna fish on it, or.
How many times a week do you eat fatty fish like tuna, salmon?
I probably have like salmon, trout, or another fish like twice a week for dinner, and then sometimes we'll have tuna fish like for a third. So it's like 2 to 3 probably.
Okay, that's helpful. And you said trout, which is also high in omega-3s, which is good.
Or and then shrimp. I mean, I probably do average easily between 2 and 3, but probably not more than that.
So shrimp isn't a fatty fish. It's good. It's got protein in it, but lake trout and wild salmon are the 2 types of fish, and actually sardines as well. They're pretty high in the omega-3s. So, okay, it seems close to sufficient. What about red meat? How much red meat do you have?
I have a hamburger about once a month.
Okay.
I just don't like meat, so maybe we'll have like steak fajitas, and I'll have a little bit then. I just don't like it.
Okay. And otherwise, a lot of chicken and poultry?
Yeah, chicken, fish, and just sort of vegetarian dishes,
So
like
what?
vegetables and farro and what else do we eat?
Okay. How many hours do you go between dinner and breakfast?
Usually finish dinner around 7:30 at the latest, and then I eat breakfast usually around 9 or so, 9:30 after I do my exercise stuff.
Great, just about 14 hours. Great. Now that's great. I think there's different schools of thought on this, but fasting overnight for 14 hours, several times a week, 4 or 5 times a week, is probably a sweet spot. It really calms down insulin resistance and helps blood sugar control.
Huh, because some people say, like my stepson's like, oh, well, you should eat before you go work out because you would do better. And I was like, oh, I like to do it on an empty stomach. So.
Yeah, it's the jury's still out, and also in some
huh.
ways it depends on what your labs look like. So
Yeah.
we'll take
Interesting.
a look at
Okay.
that. Would you open the door a little bit so that
Yeah.
Okay, exercise. Tell me what you do.
Walking is my main thing. So I walk between an hour, like an hour to an hour and a half, like first thing in the morning. About 6 months ago, I took up running. I just started running, and now I run about. I can run 5 or 6 miles. Like I try to do that twice a week instead of the walking. And then I do like little hand weight, stuff, and I do some core stuff, like lame planking. But I mean, I'm like trying to start that. I mean, I've been doing that about a year or two. But that's all. I don't do anything else.
Okay, that's reasonable. Well, when I look at all the numbers, I'll be able to get a better sense. What do you do for? Let's talk about sleep. Actually, how many hours a night do you sleep?
I'm a champion sleeper. I sleep 8 to 9 hours like every night.
Great.
I just fall asleep, and then I get up, go to the bathroom maybe once a night, fall right back to sleep. So
Do you dream?
yes, a lot.
Okay. Do you remember your dreams?
Yeah, my husband drives me crazy. I'm trying to tell him all about it. Nothing more boring.
Has your ability to remember your dreams changed over the last several years or a couple of decades?
I don't think so. I think I've always. It's like going to the movies. I mean, it's really. I think it's always the same.
Okay. Do you act out your dreams?
No.
Okay. And you ever kick your legs during sleep?
Not
Your
that
legs are restless,
I'm
nothing
aware
like
of,
that. Hobbies?
Well, I don't think I have very many hobbies. I read and I do writing, but of course those are the things that I do for my job, but I do different kinds, but those are like main hobbies that I do. I don't think I have any hobbies, no.
Okay. What do you do for stress reduction?
Like I think the walking is a big part of that. I wrote some books with the head of Duke Integrative Medicine, and so I learned deep breathing kinds of things. So I do that. I wouldn't say I lead a very highly stressed life now. I have in the past, and so I worry about the impact of that. But now not so much.
Okay. And when did you start going through menopause?
Well, I didn't know on that intake survey, I didn't know how to answer this. It really didn't allow for that because I went from taking birth control to starting HRT. I mean, I just sort of I never.
About what age?
I think I was 50. Let's see. I remarried when I was 51. And I'm talking to the doctor about that, and she's like, "Oh, well, we don't want to stop yet." So it was like 51 or 52, like when I made the switch.
Okay. And you're still on hormone replacement
And
now?
I am now, yeah.
And hormone replacement therapy and Alzheimer's risk is a little tricky.
Yeah,
And sometimes we'll check some labs, and sometimes we'll do some things. But I think the real answer to this is going to lie in what brain imaging says, and we're just still in the research phases of this. If you had to summarize, hormone replacement therapy around the menopause transition for 5 to 10 years is probably protective in a one-size-fits-all approach.
Right.
But I think the answer to this is going to evolve over time. and it may evolve depending on if I can see how your brain is looking with metabolism and amyloid and that kind of thing. So we'll talk about that another time. We do have a study that's ongoing now where we're looking at some of that stuff for women age 40 to 65. For older women who have been on HRT for a longer period of time, not really clear that that's helpful and possibly even harmful. So I think for your case, for the next several years, we don't have to really have necessarily a discussion about HRT in terms of negative effects, but this is something I'll be thinking about as we go through the general risk assessment.
Yeah, that is really interesting to me because I feel like I'm at that cut, like, oh, well, when do I wean off? When do I not? You know, it's work, everything's like great, I don't have any complaint, I don't want to, you know, and it's a real question.
Yeah, we'll try to get there, but
okay.
The chapter in the book of Alzheimer's prevention on hormone replacement therapy is not exactly written yet. Maybe the first paragraph is written, but not the whole chapter. So. Okay. Now we'll talk about family history. Now, family history, you said before, when do I need to start worrying? I'm going to ask you a whole bunch of questions about the family, and then I'll try to give you a sense of how I do this in a back of the napkin way, because we don't really know for sure. One day we will. So tell me the people that have had Alzheimer's in your family.
So my grandmother, my mother's mother.
Maternal grandmother, okay.
And
when was the very first time she started having any symptoms whatsoever?
No, I don't know. I believe she was she lived to 99 and had it for at least the last 10 years of her life. But I think she was in her early 80s or, you know, as late as 85 maybe. I don't know because I was living away from home, so I didn't see that up close.
Was it fairly typical Alzheimer's, short-term memory loss?
Yes, hers was, it started out, you know, with forgetfulness and leaving pots on, you know, on the stove, and then within a few years she was, you know, using pots to go to the bathroom, from, you know, from the kitchen if she had to, or I mean, it was really, you know, didn't recognize anybody, you know, the whole thing. Like she lived to 99, and so it was a long slog.
Who else?
My father.
My father.
So he never had, neither one of them had a diagnosis, like when any kind of neurology workup or anything. My father had a series of small strokes that you know they you know, like a doctor said, well, maybe it's, you know, it's a vascular type of dementia. So you know, don't know. That started in his maybe late 70s. Okay. Pretty late 70s, like closer to 80.
And he had forgetfulness or change?
He had lots and lots of it was like lots of forgetfulness. And then, you know, it was actually a similar sort of trajectory. You know, by the end, he also, like, he knew I was a familiar person, but I might be his sister Betty, I might be, you know.
What about your mom?
My mother died of cancer at the age of 81.
No cognitive anything?
No, she was sharp as tack.
Okay. Any other family members with forgetfulness, memory loss?
The others were all not related to me by blood, so, but, and even like my grandmother who had Alzheimer's had 4 sisters. They all lived in 97, and died of cancer and were mentally sharp. I mean, she was the one who just.
Okay. Social history. So you're married?
Yes.
How many kids do you have?
I have 4 kids and 2 stepkids.
Okay. And smoke, drink, anything like that?
I've never smoked a cigarette in my life, but I do drink.
So how much?
I probably have 2 glasses of wine 5 days a week.
Okay. That's kind of right in the sweet spot, actually, for being good. 10 to 14 servings for women. Wait, I'm sorry. Let me do the math again. 5, 10, 7 to 10 is probably the sweet spot for women. One drink a day for women, 1 to 2 for men.
Yeah.
So 7 is probably better than 10, but it's close.
So some more nights I should have 1 glass and not the same.
Probably, exactly. So yeah, goal of 7 per week. There's some other conflicting data out there that shows that any alcohol at all may be harmful for the brain, even small amounts. That was some new data that came out of Europe. Most recent review back in 2011 actually showed that 1 drink for women, 1 to 2 for men was actually protective. That's called moderate intake. So I don't know exactly, but we'll
What
take
about
a
the
look.
type? Does that have an impact?
I don't know.
No.
I think red wine makes sense, but
Antioxidants?
yeah, that's what
That's what we tell ourselves?
that's what they say, whoever they are. But I'm not sure exactly. I
Mm.
don't know. I think if I had to choose, I think red wine may be better than beer because beer has lots of carbs. I'm not really sure,
Yeah.
but red wine has lots of carbs too.
Yeah.
So,
Yeah.
and key here is also looking how much is a glass. Is it really
Mm.
is a big glass or a
Right.
small glass? And 5 ounces is
Mhm.
kind of like the right amount. Seven times a week. Okay. Any allergies?
Cats and dogs.
Oh, okay. I have cat and dog pictures over there, but they're not.
Oh.
They're not allergic. Okay. Any medicines, supplements, etc. What do you take?
Well, I take the estrogen, progesterone, and I
Do you
guess
know?
that's
Is it a patch or is it a pill?
It's actually 2 separate pills. Like I take one, one each.
Each. Okay. What else?
And it's whatever's the lowest dose, but I meant to look up the numbers. I don't really take anything else. I don't take any vitamins or, there's been times where like you're on the D vitamin kick or whatever, but then you read something and it'd be like, oh, maybe not. So
Okay.
I don't take anything.
Okay. So we'll go through all that today. It's really, really, really confusing, and the even more confusing part is probably certain people respond better to B vitamins depending on genetics.
Okay.
Certain people should probably be on B vitamins. D vitamins, maybe less evidence. Some people say omega-3s are good. Some people don't. Some people say it doesn't help. The jury's a little bit out, but what we do is we're going to look at your blood markers to try to give you a more personalized answer.
Okay.
So there's not really, a one-size-fits-all. It's not like everyone should be taking omega-3s or everyone should be taking, magic fish oil. If you're going to take fish oil, you have to look at the label. So it's all confusing. So we'll try to go through that. Okay, I think that's good for now. Okay. So most times that we see a new patient in clinic, we kind of go through the history, and then what we try to do is we try to, based on the history, give you a preliminary assessment on what you can do to reduce risk. Okay, and we'll talk about diet and exercise and everything else. You're a little different because you actually had your blood drawn earlier because you were coming from out of town.
Right.
So occasionally, what we've done is we've had blood draws out of town, and then by the time you come in, we do the A's, the Anthropometrics, body composition, at the office. We do the B's before you come, and so that we do the new patient visit and kind of like a follow-up visit all together. And then the cognitive test is what we did this morning. What did you think of the cognitive tests? Was that what you were expecting, or what were you thinking?
Yeah, I guess it was what I was expecting only because I had seen that all you, like what one was, like I didn't know, so I had sort of seen it a little bit, so I was prepared. I was surprised the variety of them, and they're kind of stressful because you're like, oh man, like I don't know my cards, like and it made me wonder, like I was like bad at certain things, like the numbers things or the cards things, and then does it all even out? Like if is that why there's so many different kinds of them? And then others you take them and you just have like no idea, like what is this test measuring or showing about me? Like the memory ones you get, but the others I had no idea. So.
Great. Okay. Let's see here. Let me get everything situated and loaded up. And then a common question I ask, right now what I'm going to be doing as we're kind of reviewing all of your risk factors, I guess. And then here's a little schematic of what we're going to do. We're going to again look at your body fat, your lean muscle mass, because you told me that you're very active, but I'm going to want to know more granularly what your numbers are. So body fat is one number. but lean mass and muscle mass is another, and we need to kind of keep that in balance and pay attention to both. Your blood biomarkers, we're going to look at all sorts of stuff, from lipids, inflammation, metabolism, nutrition, and of course some genetics. And we only look at 2 genes. The genes that we look at, one is called Apoe, and there's a 2, a 3, or a 4 different version. You get one from mom, one from dad. If you have 1 copy of 4, it increases your risk a little bit. If you have 2 copies of 4, it increases your risk more so. But if you have no copies, people can still get Alzheimer's, and if you have E4, you can not get Alzheimer's. So E4 is not really a gene that we test for risk. It's a test that we do to personalize your care. So pharmacogenomic choices, nutrigenomic choices, depending on that gene, I'm going to tell you to do different things. Okay?
Because my risk might be higher, or because of...
We don't actually use it for a risk gene, but we use it as a predictor of how you will respond to therapies. Okay? So for example, people with 2 copies of the Apoe4 gene may respond better to a certain vitamin and may respond better to a drug that's being tested in research studies now. People with no copies of the Apoe4 gene may be a little bit more responsive to lower carb diets. They may actually maybe do better from that. They may have to be a little less worried about some of their fat intake, as an example. People with 1 or more copies of the Apoe4 gene, based on some really great data out there, shows that like organic foods, for example, you say that you eat organic. In the United States and Canada, they've outlawed DDT and DDE, as an example. So if you have 1 or more copies of the Apoe4 gene, and you're getting produce from outside the United States or Canada, then you would want to buy organic from those countries. Does that make sense? So pesticides, DDT and DDE, interact with the Apoe4 gene to increase risk of Alzheimer's 4-fold. So there's all these different permutations, and that's why there's really no one-size-fits-all approach to Alzheimer's prevention. 60% of the stuff that I'm going to tell you pretty much overlaps with everybody, but then that extra 40% of stuff, you're going to be personalized based on your genes. Another gene we're going to look at is something called Mthfr. Mthfr is a little tricky gene because there's a lot of differing opinions on there. But for example, people that have elevated homocysteines in the blood, in a large study called the VitaCog study, people with elevated homocysteines, those were the people that were able to slow brain shrinkage over time and improve memory by taking B-complex vitamins. So if a person's homocysteine is normal, then we don't tend to recommend B-complex vitamins to reduce risk of Alzheimer's and slow brain shrinkage. Make sense? So there's all these like little permutations where we take different lab values. The other part is, for example, with people with high homocysteines, the only way the B vitamins work is if your omega-3 fatty acid levels are sufficient. So this again is a puzzle. It's a multi-mode puzzle where we're always refining and fine-tuning and looking at the different gauges of kind of like a car. Make sense? So that's what we're going to do by looking at all of your stuff.
And how does age like fit in with all this? Are you saying different things to me if I'm 80 or if I'm 57 or if I'm 35?
Yes, absolutely. And one of the parts that I should have mentioned before is we take your family history, right? So if you take the average age of your family members, you have your grandma that started having symptoms at 85. And then you have your dad that started having symptoms at, say, 79. You take the average age and you're right about 82. 82 minus 20-ish years, 20 to 25 years, is right in the sweet spot. So if you say to me, when's the right age to come? Well, I'd say 57 is a great age to come, and look at that.
Wow.
You're right on time. If you would have come to see me 5 years ago, I would have said, no, you got some time. So that's kind of one of the ways we do it. And then what we do is we then we retrofit the best data out there. So we take the studies, a lot of the studies out there were done in people age 55 and over. Some of the studies were done in people 75 and over. So we try to take the best available evidence and retrofit it to you, the person that's sitting in front of me. Make sense?